All right, my friends. Well, welcome to Wonderful Wednesday. And today's topic will be a posterior infarction. Say what? Really thinking about the role of the inferior infarction as a standalone myocardial infarction or in conjunction with the most common presentation, infero-posterior or lateral and posterior. So a really important perspective. When we take a quick look at this EKG, what would you actually say to this EKG? When you're giving it a quick view and an overview, remember a couple of things that we're always going to want to do. First of all, we just want to assure that when we give a quick view that there's not anything extraordinary abnormal. First and foremost, what we see an extreme abnormality here is we notice that we have ST segment depression, V1, V2, and V3. Now, it's always important to remember ST segment depression is never normal, never normal in the V leads. So whenever you see ST segment depression in the V leads, you have to always ask the question, what's going on? But I want to also remind you that if I was thinking about the heart as an oblong object like this, anterior is here, posterior is here, and the anterior leads, V1, 2, and 3, are reciprocal to the posterior leads. What that means is if I'm infarcting my posterior wall, if I was looking, excuse me, directly at the posterior surface, I would expect to see in the posterior wall, if I had leads on the back of the chest, I would expect to see ST segment elevation. But I'm not looking at the back of the chest. I'm looking at the anterior surface, and I'm seeing the opposite of ST segment elevation, and that would be ST segment depression. When we see ST segment depression in the leads of the anterior septum and the anterior wall, and along with that ST segment depression, we have an upright T wave, upright T wave, upright T wave. I'm going to think immediately that this is reciprocal to the posterior surface. Now, understanding that the circumflex, which is the lateral, and the RCA, which supplies the right side, the inferior wall, the right ventricle, and the posterior surface in most patients, that those two coronary arteries can be involved with posterior infarct. As soon as I've noted what makes me the most worried here, this ST segment depression, V1, V2, V3, I'm going to transition over and I'm going to look at whether or not there is ST segment elevation, leads 2, 3 in AVF, the inferior lead group, or in 1 in L and AVL, the lateral lead group. And oh my goodness, my friends, ST segment elevation, 1 millimeter or more in limb leads. 1 millimeter is all you need in 2 leads of a lead group in the limb leads, and 1 in L would be that lateral lead group. 1 is elevated, L is elevated, very small elevation, but this indicates an acute lateral STEMI with posterior involvement, and I've ascertained that because of the posterior reciprocals. The other component of the lateral wall could be the V5 and the V6, both of which may have a little bit of change, but not very much. So I'm going to report this as an acute lateral posterior, or actually the best way to say it, posterolateral STEMI. Get thee to a cath lab and do it right away. Okay, I'm going to involve in that also my patient's troponin levels. So you're going to see at hour 0, which was 2257, almost 2300. Hour 0, HS troponin 1471. 1 hour later, troponin is greater than 26,224. So by the way, patients losing muscle mass under my eyes, losing it fast, losing it aggressively. And along with that EKG, and most likely a typical presentation of chest pressure, discomfort, etc. This is very, very important in terms of how we're going to evaluate our patient and what we're going to consider. So always important for us when we talk about posterior infarct is to remember and to know your coronary arteries and to know your vessels. So the main vessels, and there's many more, these are just the main ones. Left main that bifurcates into the LAD and the circumflex supplying the low lateral wall. The RCA, which supplies the inferior wall of the left ventricle, the right ventricle, and primary posterior surface. And if we know our vessels, we just want to remind ourselves that we have to also understand what each vessel primarily services. So if I look at the LAD supplies the anterior LV. The high lateral LV. So that would be usually in changes that we would see in 1NL. The anterior septum, about the 2/3 of the anterior septum, and both the right bundle and the left bundle, and in particular, the left anterior fascicle. The left circumflex, which actually descends down to the lower lateral wall, the posterior LV in some percent of patients, the left atrium, papillary muscle, some of the sinus node, and very little of the AV junction. And then the right coronary artery. From my point of view, the right coronary artery, like the right ventricle, is profoundly underestimated, and we're not so worried about it when we have concerns and considerations for patients. But the right coronary artery supplies the inferior LV, the lower 1/3 of the septum, the right ventricle, the posterior left ventricle through the PDA, the posterior left bundle branch, posterior medial papillary muscle, more than half of the blood supply to the sinus node, and 90% of the blood supply to the AV node. This is really important when we're evaluating patients and we're thinking about what it is we're seeing on EKG and what we ought to be thinking about. So just want to remind you, left circumflex and its branches usually supply the posterior lateral wall of the left ventricle. The right coronary artery supplies the right ventricle, inferior, and the true posterior walls of the left ventricle and the posterior third of the septum, which means when I see high lateral changes or low lateral changes, I'm always going to look at the posterior surface. When I see inferior changes on EKG, I'm always going to look at the posterior surface. It's never right to assume that you just have a lateral infarct or just an inferior infarct. You always need to consider the possibility of involvement of the posterior wall. Now, it's really important to know your segments and waves, and it's not really my purpose to go over these basic structures, but what I want to remind you about is that you have a baseline, and that baseline is the line before the P wave, not after the P. That's the PR segment. That can move. The ST segment can move, but the line between the prior T wave and the P wave, that line defines my horizontal axis on my EKG. And it's from that line that I'm going to count up to my ST segment elevation. This is the J point where the QRS ends and the ST begins, and then we go into the T wave. So I draw that horizontal line, I count the boxes up, and that tells me how many millimeters ST segment elevation I've got. I'm going to use that same line from the TP interval, this line right here, drawn straight through, and I'm going to count down for ST depression. So we want to make sure that we understand our segments and their waves and how they relate to the horizontal baseline when we're evaluating our blood vessels. Okay. If I'm looking at ST segment elevation, say I'm looking at in the inferior wall, what I'm going to expect to see on the opposite wall, which would be lateral, is ST segment depression. If I have ST segment elevation in the lateral wall, I'm going to expect to see ST depression in the inferior wall. And the same will go for the posterior wall, which will have ST segment elevation, and the reciprocal, the anterior septum, which will have ST segment depression. Really critically and profoundly important, because generally I'm not putting leads on the back wall of the chest, looking at the posterior surface. I'm going to make these assumptions by ST segment depression, V1, V2, V3. Three things you can see: ST segment depression, upright T wave, and a big R. You don't need to see all three. You don't need to see it in every one of those leads. You only need to see it in one lead. So you're always going to be aware of that as you're looking forward at your patient. So one of the most important things to remember is that whenever we suspect that a patient is having a myocardial infarction, we always want to perform serial EKGs. Serial EKGs actually help us to capture our patient's evolution. And that's a really important thing. So this A is a normal EKG. B is the beginning of some injurious or ischemic changes, which is highlighted by this hyperacute T wave, and that is followed by your ST segment elevation. That can be followed by the loss of depolarizing mass in the myocardium. That tissue is dead now. It's not conducting current, so you get a new Q wave and a bit smaller R wave. and the STs start to come back to normal and the T wave will invert. Ultimately, what ends up is the ST is resolved. That means the acute phase is over. What's already been done has been done. I've infarcted the myocardium. That is measured by the Q wave. And I still have some injurious changes or ischemic changes, and that's actually represented by the T wave. So very important to know your waves, how to label them, what to expect, and to know your lead groups. The lead groups, when we talk about monitoring EKG, first and foremost, we talk about the inferior wall of the heart. That is visualized by the 3 leads that have the positive electrode down at the left foot. So it could be, if you're doing a 12-lead EKG, if the lead could be on the left foot, it could be on the left thigh, it could also be on the left lower chest. That lead, when it is positive in 2, 3, and AVF, is looking at the inferior wall of the heart. V1, V2 is viewing the septal wall of the heart and are going to be used very aggressively to evaluate reciprocal changes in posterior infarct. V3 and 4 view the anterior wall, and 1L, V5, and 6 view the lateral wall. Have to know your lead groups if you want to understand and evaluate EKG. So now I've just kind of put that into a framework. Lead 1 and AVL, lateral. V5 and V6, lateral. This is traditionally called high lateral, and that's actually supplied by offshoots from the LAD. V5 and V6 typically supplied by offshoots from the circumflex, but they're all lateral. That's why they're all pink. Inferior leads, 2, 3, and AVF, all green, using a positive electrode on the lower left chest, the left thigh, or the left leg, looking up at the inferior wall of the heart. V1, V2, septum, V3, V4, anterior. But from V1 to V6, this is all part of the anterior process. And when you talk about an EKG, you look at limb leads, 1 and L to look at lateral, 2, 3, and AVF to look at inferior. But that doesn't tell you anything about the anterior chest. The anterior chest is evolved, is evaluated, is seen by the utilization of your precordial leads or your chest leads. So you got to know your lead groups and your leads. And you want to remember that we talk about direct leads. Those are the leads that are directly facing the surface area with injury or infarct. Septal, V1, V2, and the reciprocal to septal, V7, V8, V9. That's left side on the back of the chest at intercostal space 5, at number 7, then shifting towards the spine, number 8, and then even more towards the spine, number 9. The anterior leads, V3 and 4, facing. Also reciprocal to anterior leads are the posterior leads. Most of us do not do a posterior EKG, and that's okay. Lateral, 1, LV5, and 6, and the reciprocals for the lateral leads are 2, 3, and AVF, and the exact opposite is true. For the direct leads, 2, 3, and AVF facing the inferior surface, the reciprocals are lateral, 1 and L, typically just 1 and L. And posterior leads, the direct leads facing the posterior surface, V7, 8, 9, and reciprocal, V1, V2. So one of the things that we think about, and this is just something really that you have to measure and you have to practice a lot, is when we see a patient with an inferior MI, we're going to talk a lot about RCA or circumflex occlusion because there's going to be a lot of shared circulation between there. If you have an RCA occlusion, the ST segment elevation is going to be higher in lead 3 than it is in lead 2, and you have ST depression in lead 1 and AVL. And you may also have some signs of right ventricular infarct. So with that RCA, because the RCA, remember, supplies the inferior wall, the right ventricle, and a large portion of the posterior wall, whenever you have an inferior MI where the ST segment elevation is greater in lead 3 than lead 2, you must always consider the possibility that you have a right ventricular infarct. Well, how we're best going to evaluate right ventricular infarct is that we might see some ST segment elevation V1, which is a right-sided lead, but also if we took off lead V3, V4, V5, and 6, put it over on the right chest, making us now a right-sided EKG, what we would expect to see is In V4R, what we would look for was ST segment elevation. That's it. And that's going to tell us that this is a right coronary artery occlusion. So my friends, when you're looking at an EKG and you're looking at those inferior leads, and ST elevation is greater in lead 3 than it is in lead 2, you're always going to want to consider the possibility of a right ventricular infarct. In that case, it might be very helpful for you to actually take the leads off the left chest from V3, 4, 5, and 6, and put that over in the exact same position on the right chest, V3R, V4R, V5R, V6R. And what you're looking for is ST segment elevation. Most commonly, right ventricular infarct, what you will see is ST segment elevation V4R. And that's the only thing you're looking for is ST segment elevation. If the occlusion is in the circumflex, and remember, there's some shared circulation to the inferior wall between the RCA and the circumflex, you are going to see if it's a circumflex occlusion, typically ST segment elevation is greater in lead 2 than it is in lead 3. So that's pretty straightforward. You just swap it out. And actually, you typically will not have ST depression in lead 1 and AVL. Now, remember, with RCA occlusion, you're going to have ST depression in 1 and L when you have ST elevation in the inferior leads. But with the circumflex occlusion, because it's a little farther away, it's not quite as potent, you're not going to see reciprocal ST depression in leads 1 and AVL. So really, really important when we're understanding this and delving into a higher evolution of EKG knowledge to appreciate that the posterior wall can be serviced by the RCA and or the circumflex, which is why, first and foremost, you're looking at an inferior MI, trying to determine is it from RCA occlusion or from a circumflex occlusion. And these are things you just have to memorize and appreciate and understand. So now we take a look at an EKG from an RCA occlusion. And you can see in this EKG, as you look at it quite quickly, you see that you have ST segment elevation lead 2, ST segment elevation lead 3, and a little bit in AVF. But the most significant elevation is in lead 3. Okay, now that's really important for us. Lead 2 is a little bit less, lead 3 is a little bit more, and I may have turned these upside down, but I don't think I did. Okay, so this was an RCA occlusion, and down here we're looking at a circumflex, and you can see you've got ST segment elevation lead 2, but a bigger ST segment elevation also in lead 3, and that's why I think I may have turned them around. I'm sorry if I did. But really important is that we all see that we have ST segment elevation here in 2, 3 and AVF, here and also here in 2, 3 and AVF. And I don't really have much ST segment depression, just about a 1 millimeter in lead 1 and a little bit in AVL as the reciprocals. And here I don't have really any because it's a circumflex lesion. I don't have ST segment depression in lead 1. I do have a little bit of AVL involvement. That's really from the circumflex lesion itself. Okay. Everybody loves to talk about anterior myocardial infarction, but the one that I'm really also very worried about is the inferior STEMI. So remember, inferior STEMI is highlighted by ST segment elevation, leads 2, 3, and AVF, all sharing the same positive down at the lower left chest, the left thigh, or the left leg, looking up at the inferior wall. And as you're evolving this and as tissue is dying, your R wave will get smaller and you'll start to develop a Q wave, the absence of electrical depolarization under the lead that's looking at that surface. It is important to remember that you will see reciprocal ST depression AVL, and some may be more or less in lead 1, but definitely in AVL. 50% of all MIs are inferior. So somebody I had an EKG class today, and in my EKG class had a bundle of EKGs that he had collected as a paramedic and running the paramedic desk and being on ambulance and being a cardiac paramedic. And by far, the abundance of them were inferior MIs. It's the most common MI is the inferior MI. Now, the wonderful thing about the inferior MI is if it's just an isolated inferior wall, you're going to have a pretty favorable prognosis. It's just the inferior wall of the LV. If you've got a preserved posterior wall, preserved right ventricle, the likelihood is you're going to do pretty well. The mortality in hospitals is only less than 10%. Up to 40%, though, of patients who have inferior MI, up to 40% also have a right ventricular MI. 40% of the patients that you look at who have inferior MI, inferior STEMI, 40% have a right ventricular myocardial infarction, and you won't know it if you're not looking for it. That's a much worse prognosis if you've got an RVMI. Much worse prognosis. Lots of times those patients might not get treated appropriately and they die almost immediately. Up to 20% of those patients have a significant bradycardia because the AV node is supplied by the RCA, 90% supplied by the RCA. So you can have a very significant block from Mobitz type 2 to complete heart block. And again, that's going to increase your hospital mortality. But by the way, my friend, if you have an inferior MI with posterior involvement, that is the worst possible prognosis of just about any MI, certainly of the inferior groups. And the way we know that you're having a posterior MI is by evaluating the reciprocal changes in V1, V2, and V3, which is ST segment depression. So we take a quick look at our inferior MI right here. We're looking at leads 2, 3, and AVF. What you're seeing here is a non-acute process. Patient has already had their acute changes, and what they have developed here is a Q wave, a Q wave, and a Q wave. These are Q waves in the inferior leads. That is completely abnormal, and the Q waves in the inferior leads are indicating to us that we have had a patient who has infarcted his inferior wall. ST segment tells us that it's acute. The Q wave tells us about myocardial tissue loss. So you can see we don't have ST segment changes here. We do have an inverted T wave, so we're still resolving our myocardial infarction. I wouldn't call it old yet. T wave has to be upright before I can call it old, but it's definitely not acute because my ST segments are normal. And I have big, deep Q waves in my inferior leads. So I've infarcted the inferior wall. Then I'm going to go over here and look at this other EKG. You can see you've got this teeny tiny Q wave in lead 2, much bigger Q wave in lead 3, which is very common. And then the next largest in the AVF lead, smallest in lead 2. So really, really important to appreciate that once that Q wave appears, you have a very narrow window of opportunity for resuscitation of the myocardium, and your resuscitation is going to occur while the patient has ST segment elevation. Once the ST segments have returned to normal, the process of murder of myocardium is over with, at least to the large majority, the murder of the myocardium. Kind of like that, murder of the myocardium. I need to remember that for some kind of a talk somewhere, somehow. Okay, so complications of inferior wall MI, remember 40% of those patients have right ventricular infarct. When you have a right ventricular infarct, you actually have significantly damaged the right ventricle. You probably also have some damage of the left ventricle, but the ejection of the right ventricle will be severely limited, and therefore left ventricular filling will be limited, left ventricular ejection will be limited, and your patient will be profoundly hypotensive. And with what one might have thought, looking at the EKG, a simple inferior MI, the patient goes directly into cardiogenic shock. Typically, not always, typically, with right ventricular infarct, the patient will be profoundly hypotensive, which is why, in general, we do not advise the utilization of nitrates or morphine or other pain management methodologies with a patient who has a suspected or known right ventricular infarct. The only way you know is to take those left-sided leads off and put them on the right chest in V3R, V4R, V5R, V6R, and evaluating for the presence of ST segment elevation, most particularly in V4R. So very, very important to appreciate that the right ventricle in its very best scenario, in its best life situation, the right ventricle is a volume pump. So first, before anything else, the patient's going to get volume. Now, I might be able to give them morphine or nitroglycerin or nitrates after giving volume, but I'm always going to give volume first. And I want you to remember that 55% of the sinus node is supplied by the right coronary, which also supplies the inferior wall. 90% of the AV node is supplied by the right coronary. So I'm going to anticipate some significant issues with conduction from sinus node through AV junction down to the right and left bundle branches. Okay, so take a quick look at this patient. Okay, we saw them already once before. Is this inferior, lateral? Oh, excuse me. I'm in a freezing cold room and I think I'm getting a pneumonia. Not really, but it's quite cold in this room. So is this inferior? Is it lateral or is it posterior or any combination thereof? So again, remember, as you look at your EKG, our purpose here today is really just to talk about whether or not you see ST segment changes. So when I look at this, I always look in lead groups. I'm going to start with lateral, 1 and L. I think there's mild elevation in lead 1 and AVL. And remember, the limb leads, any elevation greater than 1 millimeter is considered abnormal. That's not true with the chest leads, but with the limb leads, any elevation greater than 1 millimeter is considered abnormal. So it looks to me like I've got some mild elevation 1 in AVL. That looks like I'm having a STEMI in the lateral wall. 2, 3, and AVF don't have ST segment elevation, maybe have a tiny bit of depression in lead 3. I'm probably okay with that because I don't have such significant electrical changes in 1 and L that they actually are instilled reciprocally yet on leads 2, 3, and AVF. But I want to remember whenever I have a lateral infarct, or if I were having an inferior infarct, I immediately go over and look at the reciprocals for the posterior wall. And indeed, here we are, ST segment depression, V1, V2, V3. T waves are upright and the R wave is relatively large. So sorry. I'm about to completely lose my voice. So that's really, really, really important. This is a posterior lateral acute STEMI. Okay. Now remember, when we talk about inferior STEMI, you must always consider right ventricular MI. That is typically only seen with a high grade or proximal right coronary artery occlusion. So I have an inferior MI, I have an RVMI, and I'm always going to use that right-sided EKG placement to evaluate the right-sided EKGs. And remembering that in those right-sided leads, so that would be V1, V4R, I'm sorry, V1, regular V1, V3R, V4R, V5R, V6R. I'm looking for ST segment elevation just at 1 millimeter or greater. And I'm especially looking for that in V4R. That RVMI, subtle, very easy to miss that RVMI, and it significantly and profoundly affects your patient's trajectory. So again, RVMI, I'm going to look for mild ST segment elevation V1, ST segment elevation in lead 3 greater than lead 2, because lead 3 is a more rightward facing lead than lead 2. And if I have significant ST segment elevation V1 higher than elevation V2, or if this ST segment elevation V1 is flat and the ST segment in V2 is markedly depressed, I'm always going to observe for other issues. I'm going to look for RV infarct. I'm going to look for posterior infarct. That's the problem, because these changes are subtle and require a lot of attention to detail. So this is our patient. Here's my patient's left side. Here's my patient's right side. I've taken all his left side leads off and I put them over on his right side. So V3R, V4R, V5R, and V6R. Okay. So remember, this is going to be something I'm going to look at the point of time that my patient is presenting with an acute inferior or an acute lateral wall MI. It's very transient, and typically the changes that we see, the changes that we see don't really last very long. So I want you to realize that what I'm showing you right now is the right-sided leads. You have to trust me because it doesn't say R. That has to be manually written on there. But what you're looking at here is you see that you've got ST segment depression V1, indicating that this may be a posterior infarct. And when I look at V3, V4, V5, and V6, but these are all on the right side of the chest, you see that I have ST segment elevation. You have to trust me that these leads were placed on the right side of the chest. So V3R, V4R, V5R, V6R, correlating with this, and actually identifying ST segment elevation. And that is not going to last for long because it's an acute process. So we're not looking for Q waves. We're not looking for anything else, just looking for ST segment elevation. Okay, so that's really important because it really drives our clinical practice. Okay, so V4R, so that here you can see it's marked as V4R, most commonly used right-sided lead, the one with the greatest value in indicating a right ventricular infarct when you have an inferior wall infarct. That's really important. I'm not just doing right-sided EKG. I'm going to do a right-sided EKG when I have evidence of an inferior STEMI. So let's look at that. Here are my limb leads, or my normal standard limb leads. Lead 1 in AVL, both with ST depression. I'm going to look at the opposite wall to see if I can find ST segment elevation. Opposite wall, 2-3 in AVF. Now I'm looking at 2-3 in AVF, and there's significant ST segment elevation. For me, the next step for me is I'm now going to look at V1, V2, V3 to look for posterior reciprocals. And I'm going to apply right-sided leads, taking V3, 4, 5, and 6 off of the left chest after I ran the EKG, putting it over on the right chest in order to look for ST segment elevation. So I can say here, I'm having an acute inferior STEMI, no posterior wall involvement that I see, but via my right-sided EKG, I have ST segment elevation V4R, so I am actually involving my right ventricle. So I'm infarcting both the right ventricle and the inferior wall of the left ventricle. So lots of things that we can memorize and know, but most importantly is this. Your patient has acute inferior changes on EKG, view posterior reciprocals if they're present or not, and consider a right-sided EKG to rule out right ventricular involvement, to rule out or rule in right ventricular involvement. If you have a right ventricular MI, no matter how severe the patient's pain is, you will not give him pain management that causes any form of venodilation, so that be morphine or nitroglycerin, other agents as well, fentanyl dilaudid, etc. Not going to give anything that promotes venodilation until the patient has been volume loaded. Oh no, you say it's a cardiac patient. His neck veins are distended. His CVP is elevated. That's all from the loss of his right ventricular compliance. He needs volume. And so we're going to give him volume first, and then we'll treat his pain with some type of medication that is going to second-handedly, or actually a primary venodilator like nitroglycerin or morphine or other analgesic agents, which in an indirect way are going to promote vasodilation. Okay. So what we can see here is the same thing that we talked about before, the ST segment elevation lead 3 greater than lead 2, ST depression in lead 1. Okay, so big ST segment elevation here, even bigger in lead 3 bigger than 2, ST depression in lead 1. This ensures that this is a right coronary artery occlusion. Okay, so that really gives us a lot of information when we're looking at the patient. We can suspect it. We have some other problems as well. We're not talking about those just now. Okay, so let's take a quick look at a patient. So a patient admitted to the emergency department on February 27th, 2022, 64-year-old man, known history of type 2 diabetes, comes to ED as a STEMI alert, alerted for STEMI activation, alerting the cath lab from the ambulance. He's notable for hypotension, and they gave a full exam and a lot of information. But he got 160 milligrams of aspirin in the ED when he arrived. STEMI alert was activated prior to arrival by EMS, and because of his hypotension, he received a pressure bag of 1 liter of fluid that was sodium chloride, and his blood pressure improved to 120 systolic. The cardiology team came to look at the patient, didn't note any severe wall motion abnormality while doing a POCUS or an echo, but they did notice that the RV looked dilated. Because he was having severe chest pain, they wanted to be sure that he wasn't dissecting his aorta. Seems like there was no concern for that. No concern for embolism. On the way from CT, or on the way to CT, he had multiple PVCs and several runs of VTAC, and his point of care troponin was 0.11. Okay, so that was really, really important. when we're looking at that patient. 0.11 times 1,000 gives you HS troponin. And because he kept having this unstable rhythm with VTAC and PVCs and the diagnosis wasn't clear, the decision was made to take him to the cath lab. Okay, here's his first EKG. That's at 3:30, okay? And when you first look at this EKG, you give it a quick once over. There's things we can look at, axis, R-wave progression, all sorts of things. But what we're looking at for right now is, does he have ST segment elevation? Okay, so we look at lead 1 and AVL. These are not elevated. There may be some minor depression in AVL. I then go to lead 2, 3, and AVF. And I think that you have some minor ST segment elevation, certainly in lead 2 and lead 3. Very hard to know about AVF because I don't have a very good signal on AVF. But also really important, note the distance of the P wave from the QRS. And also note that the P wave is not always related to the QRS. In fact, you got a little P wave here. In fact, you have, looks like a P wave here, P wave here, P wave here, P wave here. The P to P interval is constant. You have, at the very least, you have 2-to-1 AV block, but I think actually you probably have complete heart block. And remember, that's something that we're going to anticipate with somebody that we think has a right coronary artery occlusion, because that's one of the things that you'll see is abnormalities in conduction through the AV junction. So really, really significantly and profoundly important when we're evaluating the EKG. I'm so sorry, I'm just sending got an urgent message about a patient. Okay, fantastic. And then I'm looking over here at V1, V2, and V3. And this is, I don't really have much information here, right? I kind of have a half beat here and a full beat here. It looks like I do have a little bit of ST segment change here, but I can't be sure. This is not a great EKG. I need a better EKG, and I want the EKG tech to rerun the EKG, or I'll do it myself. Okay. At 11 a.m., so the first EKG was at 3:30. Now we're at 11 a.m. Cardiology has seen the patient. Patient seems like he's feeling pretty good. He's got elevated blood pressure. He actually went to the cath lab. He had a TR, or he had a radial insertion. So his radial site actually is applied with a TR band. His pulses are intact. Everything seems okay. You can see he's got quite a little history. And the discussion that he went to the cath lab, and they found that he had an RCA culprit lesion, and in more than one place. So he had a proximal and 2 distal lesions in the right coronary artery, and he got 3 drug-eluting stents. He got aspirin in the ambulance, aspirin in the ED, got Plavix in the cath lab, pre-procedure, and Aggrastat bolus post-stenting. Okay. He had VF twice during his case that both required cardioversion, and that was successful. But I want you to note what cardiology has written here, like this. This is how it was written in the chart. No diuresis, exclamation, exclamation, exclamation. Do not diurese, because this patient has an RV involvement. He has an RV infarct. He has moderately reduced ejection fraction with right ventricular wall motion abnormality and a dilated right ventricle. He has a right ventricle that is not particularly functional. So we're not going to ever diurese him. We're going to be very cautious when we give him, if we give him any nitro, because we don't want to delay the return of volume to the right heart. Now, 15 to 20% of inferior or lateral STEMIs actually have a posterior involvement. Okay, so that means you've got a lateral infarct, think posterior, look for posterior reciprocal. You have an inferior infarct, think posterior, look for posterior reciprocal. Posterior reciprocal, V1, V2, V3, ST depression, T wave is upright, and the R wave may be bigger than you would have expected. But we got some good clues there. Oh, you're having a posterior, you're having an inferior infarct, think posterior. Oh, you're having a lateral infarct, think posterior. The problem is the isolated posterior, which goes most of the time unrecognized. And thank goodness it's not that common. It's less than 12%. of patients actually have an isolated posterior wall involvement only. But the problem is it isn't often recognized. So that's the idea of what we have to consider. Remember, if this was my posterior wall, I'd be seeing ST segment elevation, but I'm not looking at the posterior wall. I'm looking at V1, V2, V3, and what I'm going to look for in those leads is ST segment depression. So for posterior involvement, we're always going to read it, at least first, we're going to read it in the anterior reciprocals, which are the opposite changes. So your patient will have what we call horizontal, which means a flat plane, like a drop in the ST segment. So it's a flat plane, horizontal ST depression, usually a big R wave and upright T waves. And that's really, really important. ST depression, upright T wave, and a relatively bigger than expected R wave in V1, V2, and V3. Okay. Now, if I put leads on my patient's back, V7, 8, and 9, I'm looking for ST segment elevation, and the probability is that I will also see Q waves. So here is the reciprocal. And you can see this horizontal ST, which means just like an elevator went down. It's not a slope down, it's a go down. And that's a horizontal ST segment depression. T wave is upright and a big R wave. This is reciprocal for a posterior infarct. Now I put a lead on my patient, and in V7 or V8, what I see is this very deep Q wave and this big ST segment elevation. But I have to suspect that you're having a posterior infarct to actually put the leads on the posterior surface, because I got to turn my patient, put the leads on the back. I've got to have an EKG tech who's willing to wait around to take a look at the posterior surface. So again, really important to think about that lead placement, just actually palpating the scapula, and really it's about the fifth intercostal space, V7, V8, V9, okay? V7, V8, V9. Now, that ST segment elevation that you're going to see there is typically not really huge. Lots of times it's 0.5 millimeters, so it's half of a box, and that's all you need to make the diagnosis of posterior myocardial infarction. So now we look at it on this patient, and on a patient who is actually not this person, this is a model, but on a patient who is having a posterior infarct, what you see is here's your anterior wall, your reciprocals in V1 and V2, and here is direct leads looking directly at that posterior surface, which is dead, 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 V8, V9, ST segment elevation, and small Qs. That helps me to confirm this. So again, I want to remind you the most common time that you're going to see a posterior infarct is with an inferior MI. With an inferior MI, and we call that the infraposterior myocardial infarction. Now, I've given you all the criteria, and I've said it multiple times, and I want to make sure you appreciate that whenever you see inferior changes on EKG, your eyeballs will go directly to V1, V2, V3, looking for those reciprocal changes, the horizontal ST segment depression, the upright T, and the relatively larger R. So really, really, really important. Remember your segments and your waves. And remember, reciprocal is the direct opposite of what you see on the direct side. The direct side with the posterior infarct is with your posterior leads. And you are clued in to the posterior infarct by looking at the reciprocals in the anteroseptal leads V1, V2, V3. So let's take a quick look at this patient. Okay, and we're going to look along our patient. We're going to say, okay, I'm looking first at the lateral leads. I might have a little bit of elevation here. Don't have any elevation AVL. And so those are my lateral leads. Then I'm going to also include V5 and 6. Got a little elevation here. Okay, so I've got a little bit of elevation in the lateral leads. But when I look at leads 2, 3, and AVF, I have a much more significant elevation in the inferior leads. So I'm going to call this an inferior STEMI. And even if you were calling her a lateral STEMI, then the very next thing you need to do is look for the posterior reciprocals. ST segment should be flat on the baseline, but here it's depressed. Flat on the baseline, here it's depressed. Flat on the baseline, here it's depressed. ST segment depression, which correlates to the posterior surfaces, ST segment elevation. Okay, so now we come down to this next EKG view, same patient, but now we're looking at V4, which is basically what they did is took off 4, 5, and 6, which you have to do, and put V4 at the 7th position. So you'll see it's marked 7, 8, and 9. It's the V4, 5, 6 leads taken off the left chest, put on the posterior surface, and you indeed see that your patient A has ST segment elevation and B has a Q wave. Your patient's having an acute infraposterior infarct. So this is pretty concerning. This is pretty concerning because you're incorporating a lot of walls into your damage and you need somebody to really be paying attention. Okay, so again, we're going to look at this patient, another infraposterior infarct, very mild ST segment elevation, 2, 3 in AVF, largest in 3, second largest AVF, smallest ST segment elevation, lead 2. Because it's an inferior STEMI, I'm immediately going to look at posterior reciprocals. And in the posterior reciprocals, I see ST segment depression, 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 upright T, upright T, upright T, and a relatively normal or large R wave for those positions. This is an infraposterior infarct. Okay. Again, another very significant posterior infarct along with inferior. So what you're looking at here, in 1 in L, you see ST segment depression. First thing you're going to do is look at the reciprocal. The reciprocal is the ST segment elevation, 2, 3 in AVF, inferior, acute inferior STEMI. Because I'm having a STEMI in the inferior wall, I'm immediately going to look at my posterior surface. And I can see ST depression in V1, V2, and V3. I even have it into V4 and 5. That means a large surface area of the posterior wall is infarcting. To inscribe ST depression across the anterior wall, so I'm looking at, let's see, V1, V2, V3, V4, 5, and 6. And I'm seeing ST depression all the way across the anterior wall. That most likely indicates that my whole posterior wall is involved and causing that very profound reciprocal change. Okay, so when we just take a quick look at the V leads in another patient, you're drawing your horizontal axis from the TP interval, and you can see that you have ST segment elevation. Okay. Now we're going to take a look at another posterior infarct, and this one's going to be the most important one, I think, because when I look at lateral, I got a little bit of roundness there, but I don't really think it's anything too significant. My doctor said, nah, no lateral changes, really don't have any lateral problems. Look at 2, 3 in AVF, don't really have any problems. Go over here and take a look at V1 and V2 as the septal leads, V3 and V4 as the anterior leads, and V5 and V6 as lateral leads. And what I note is I have significant ST segment depression, V2 and V3. Got a big R wave and ST segment depression. This indicates to me a standalone posterior infarct. And I'm really worried about that because it's easy to miss. And I have to be an advocate for that patient to say, my patient, I think, is having a posterior infarct. Can we get cardiology to look at it? Can I ask cardiology to look on the EKG device, or we call it TraceMaster, where they can actually see the EKG so that we can make some good decisions about what's happening for this patient. This patient is having a standalone posterior infarct, the infarct that is the easiest to miss and can be very, very significant. Okay, so going to take a look at posterior 1A. Okay, so we're looking at this patient. I'm not an excellent cath lab reader. You don't need to be either. But as we look at our right-sided picture, here's our left picture. That's the anterior oblique view, and the anterior view on the right side. You're seeing that your left main bifurcates into the LAD, and I have complete stenosis of my circumflex. Okay, I also have a huge stenosis in the left anterior descending coronary artery. So we can see that we have a patient here who's got significant stenosis in their left anterior descending artery and also in their circumflex, which then leads us to a posterior infarct. So again, we're going to go back here and we're going to look at this patient. Okay, this is the same patient that the cath was. And you see, you might have a little depression in one, not any in L, no elevation 2, 3 in AVF. I go to my V leads and I say, I'm going to look at V1 and V2 as anteroseptal. Uh-oh, ST depression in V2 with an upright T wave. Think that might be posterior. By the way, for reciprocal changes, doesn't have to be every change, and it only has to be in one lead. Doesn't have to be in two leads of the lead group like the direct changes are, like the indicative changes, the leads that are facing the area. This is the opposite area, and I only need changes in one lead of that lead group. Okay, one more really good one. This is an infralateral posterior infarct. So this really tells us a lot about where the occlusive disorder is in the coronary arteries, helps us to anticipate when we go to the cath lab what we're going to find. You can see ST elevation in lead 1, not much in AVL, ST elevation in leads 2, 3, and AVF. Going over here to the other lateral leads, V5 and V6, ST segment elevation, and then saving the best for last, V1, V2, V3, and V4, really representing reciprocals for the posterior wall. I have ST segment depression with upright T waves. This is one sick cookie. One sick cookie. Okay, so again, on this patient, we actually apply that V7, V8, and V9, looking for ST segment elevation in the posterior surface. I myself would probably say, I think I probably also want to look at an RV EKG, but I'm cool if I've done the posterior. I'm just going to be really cautious. If the patient is hypotensive, not going to give him nitrates, not going to give him morphine. Don't want to give him anything till cardiology sees him. And I'm going to be very tenuous about giving him anything that's a venodilator or an arterial dilator, because I don't think he'll be able to manage it. So now I go back and I say, what would you say to this EKG? What you would say to this EKG is, I think your patient is having an acute posterior infarct. He may have some lateral involvement, one in AVL. This is the EKG we looked at the very beginning. ST segment elevation in lead 1, ST segment elevation in AVL. The other lateral leads, V5 and 6, they don't look really elevated, but because I understand the lateral delivery of blood and oxygen can also affect the posterior wall, I look at the posterior wall and I have horizontal ST segment depression with upright T waves and a big R. Patient's having a posterolateral infarct. Okay, remember that patient because he was the first patient we looked at in that 1 hour, from 0 to 1 hour of his high sensitivity troponin went from 1,473 to 26,000. The delta you're looking for is 5. You're looking for an increase in 5. Your patient had an increase of 2,500 almost. 2,500. Not 2,500. 25,000. Oh my goodness. Even worse. 25,000 increase in troponin. Okay, so just a couple of other folks that we just can take a look at. This is a patient who comes to our emergency department. They activate a STEMI, interventional cardiology, comes to see the patient. Patient has an elevated lactate and elevated troponin. And he goes to the cath lab and he gets a PCI to the proximal left circumflex. That was his EKG that we looked at before. That was his EKG. Thank goodness people were paying attention. Thank goodness we opened up his vessels. And this is him 4 hours later. And you can see the ST segment depression is primarily resolved. The ST elevation in 1 and L is resolved. And the patient looks significantly better by EKG. And also the patient himself looks significantly better. Another life and another myocardium saved by excellence, by bedside nurses, physicians working together, APPs working together, cardiology and cath lab working together. Another life saved by excellence, by intuition, by knowledge, and by evidence. Thank you so much for everything that you do every single day. I'm so grateful you joined today, and I hope to see you next week for next week's Tuesday and Wednesday talks. Thank you very, very much.